next speaker, if they are there. Changes in binocular corneal innervation and binocular imbalance after unilateral smile and TPRK. Chief presenter is Liang Hu. Next, Thomas is not here. Thomas KOHNEN. Please, you are here. And he's going to talk about safety and efficacy of customized photorefractive keratectomy treatments, followed by corneal cross-linking in patients with keratoconus. Yeah, please come this side. Thomas is a very well-known refractive practitioner in Europe. He's been a president of EACRS, and we are proud that he's come to AIOC this time in New Delhi.
Thank you. Thank you for the kind words, the nice introduction. Yeah. Okay, I will have two talks, and one is basically on the photorefractive keratectomy treatments following by cross-linking. So you know that cross-linking was actually introduced 2000 in Germany and Dresden with Theo Seiler's group. It's a paradigm shift in keratoconus management over the years. And you can see that the publication was in 2003. They started this, but they, described and introduced it 2003. It's a minimal invasive and safe method for whole progression in keratoconus, which is, it's a treat for those patients who have a keratoconus. We're happy that we have that. You know, the principle is riboflavin catalyzes the photosensitization in cross-linking treatment, production of single oxygen, and then the reaction of singlet oxygen with nearby groups in corneal collagen fibers and protoglycans actually producing these stronger bonds in the collagen after the treatment. So we have enhanced biomechanics. Here's a paper, Evidence of Focus, Pioneering Studies on PRK plus collagen cross-linking. The reason is, when you have these patients, you only cross-link them, they still see not very good because they still have the cone. Now we're all searching for something to help them even further. That's a pioneering work, prospective interventional non-randomized clinical trial, 17 patients, 34 eyes with progressive keratoconus, whereas 17 eyes got PRK plus cross-linking. And here you can see the outcome in comparison. Evidence in Focus pioneering studies actually showed that you can get better outcomes in terms of visual acuity if you put some evidence of PRK on top of it, so to normalize the cone. I will show you one patient. We have like several ones, only a small series. It's a 40-year-old patient, female, history of keratoconus, initial diagnosis when she was 21. The refraction was plus 2.25, minus 5.5 in one eye, left eye with 7.5 diopters. And without correction, she was 0.3 in both eyes. With correction, she was quite good, 0.8 to 20/20 in the left eye. So here you see the corneal topography with the oculus pentacam measurement. You can see on the upper left side the power map, and you can see the posterior map up right there, and you see typically the lower cone here. So here is the laser profile which we have used. This was done with a Schwind Amaris laser. I consult for both companies, for Oculus as well as for Schwind. And you can see here the laser profile. Rules for ablation profile is according to the Essence protocol, our colleague from John Kanellopoulos. Maximum ablation on conus is less than 50 microns. That's very important. And the residual corneal stroma thickness should be above 400. That excludes a lot of patients to do this. Because what we don't want to do is we don't want to take a cone, ablate him, and that he get worse, and then you anyhow have to do a penetrating keratoplasty. So this is a profile. This is the pentacam post-op. There is some regularization of the patient. Here you see the flattening above the cone. If I do the difference map on the right, post versus pre. And here are the outcome of basically 5 patients. So we have a small series. If you look at if you look at at the outcomes, you basically can see that the post-refraction has a reduction in 4 out of 5 cases highly. 4.5 was left here, but he had 7 diopters of astigmatism. And you can see that the visual acuity actually increased in most of these patients. Best corrected visual acuity did not decrease, and we had 20/20 in almost all these cases. So in summary, the cross-linking caused a paradigm shift in conus management. PRK and cross-linking might be the next step for corneal stability plus better refractive outcomes. With this, I would thank you for your attention.
I think that's a very exciting area, no, to have a customized cross-linking in these cases of keratoconus. I think if you look into last 2 decades of management with cross-linking, things have changed so much, and the requirement of surgery like DALK has really gone down in these cases. And we pick up these patients early and manage them, very good effect. Any questions for KOHNEN? Yeah.
Yes, these are all topography-guided ablation zones, which we really meticulously measure and calculate. You can do it with a software. We do it with the company because we really take that 50 microns, 400 microns. If that doesn't fit, then I don't do the treatment because it becomes too dangerous. It's also in my country, we have this as a limit range of indication for conus treatment. I think the jury is still out if they hold for a long time. We don't see a 10-year follow-up of these patients, so let's see. We're just investigating on these patients. They know that. No, you cannot do non-topographic because you have to customize your treatment. If you do a normal laser treatment, you basically take away 20, 30, 40 microns all over the cornea. What you have to do is you need a topography guided because you have to selectively, ablate tissue. You cannot do it with a non-topography guided excimer laser. Not possible.
Okay, thank you. Let's go into next, your